Okay, thank you, Dean. This is Sue Tebb, and I'm honored to introduce our speaker today. And as Dean reminded us, we're doing a little different today, so Adobe Audio is disabled, so we're using the phone. And so just to remind you to do mute unless you're speaking. Our speaker today is Robin Golden, and I'm honored to say she's a social worker, and she serves as Director of Health and Aging at Rush University Med Center in Chicago. She also holds academic appointments in the Department of Preventive Medicine and Health Systems Management. There, she's responsible for developing and overseeing health promotion and disease prevention, mental health care coordination, and transitional care services for both the older adult, their family caregivers, and people with chronic conditions. Over the past 25 years, she's been very active and involved in service provision and program development, both education and research and public policy, in helping to improve the health and well-being of our older adults and their families. In 2003 and 4, she was a John Hines Senate Fellow, something that I've always admired, and she was based in the office of Senator Hillary Rodham Clinton at the time in Washington, D.C. She's also past chair of the American Society of Aging, and she currently chairs the National Coalition on Care Coordination, housed in New York Academy of Medicine. She's also a fellow of the Gerontological Society of America, and she holds a master's degree from the University of Chicago in the School of Social Service Administration, and also a bachelor's degree from Miami University. And I think today, her talk to us is on mental health and aging, and I like to always bring people aware when we're dealing with older adults, how mental health, aging, and healthcare all come and intersect, and I think Robin will do a great job in presenting that. She's got a great PowerPoint that she has put out there for us. So I'm going to turn it over to Robin today, and I think she's going to be joining a number of our colleagues tomorrow for the National GSA meeting. So Robin, thank you so much for coming today and speaking to us.
Thank you, Sue. Such a nice introduction, and thank you, Dean. You've been amazing putting this all together. So yeah, this is such an important topic. You all know, based on your work with older adults and GECs, et cetera, how critical it is. So I'm so glad you wanted to hear a little more about it today. And I think if we just start off with what the issues are, that mental health needs of older adults are so complicated because of that intersection that Sue just mentioned, the physiology with the cognition, with the social functioning. It's a perfect storm very often. Good, we got the music off. And that mental health and well-being are absolutely critical to people's optimal functioning, their physical health, their satisfying social relationships. But with that said, it still is often a stepchild to the whole discussion about overall health outcomes. And that'll be the theme today. So you'll be hearing that over and over in different ways and what we might do about it. Some of what happens most critically is that people present, if they do present with mental health issues, often present to their physicians, and typically their primary care physician. And unfortunately, though, it has a tendency, because of the way primary care is set up, that we sometimes miss this in this arena. But they will go to their doc first, so it's so important that that physician is open to hearing about depression, anxiety, hopefully open to screening about it, and more are doing that. But, the fear that a lot of primary care physicians have is that they don't, they feel like if they do ask those questions, because something like 50 to 75%
Margaret Springer
of all primary care visits could focus on a mental health concern, they're sometimes afraid of opening that Pandora's box. And what will they do with it when someone does have a mental health issue? And there's something to be said for what they're saying. The mental health services in our country have been diminished somewhat over the last few years. So many mental health problems in older adults go undetected by primary care providers, particularly in men and minorities. So that's really and why it's so important to think about screening tools to raise these issues. If the person who just came on, maybe you didn't hear it, it would be so great if you could mute.
Yes.
Terrific, thank you. Older adults are more likely to present symptoms in language that is ambiguous to the provider. So very often people will talk about their feet hurting. I hate to sound so simplistic, but it'll be much harder, particularly for older adults, to talk about their feelings and their pain. It's just so often a cohort issue. This is not a population that's done that. When they did do that, maybe they were so afraid that it would be interpreted in a way that it was a much bigger issue, that they were quote unquote crazy, those sorts of things. So again, even when mental health problems are recognized, clinicians anticipate a poorer prognosis for older than younger adults. And this is some of that bias, that ageism that we so much try to combat in our work. And they're less likely to refer older adults for treatment. Remember back when, if some of you really know mental health and psychotherapy, the father of psychotherapy and analysis, Sigmund Freud, basically said that once people hit 40, there wasn't a lot of plasticity to change. And for those of us who work with older adults, particularly clinically, know now that Freud was wrong, and that people who are older have just as much, if not more so, greater likelihood to make changes and embrace new and different things as they grow older. Yet, there's still a lack of referral and attention to it. Primary care clinics rarely employ mental health providers to address this issue. Now, that should be changing some with some healthcare reform, but it's still looking that way. The U.S. Surgeon General issued a report that identified primary care as a pivotal point of care for older adult mental health. Remember, if patients and older adults trust anybody, it's their primary doc, right now this cohort, or their clergy. So those are usually the best places to identify issues of mental health that are being unaddressed. And, part of the issue that gets in the way, too, is the random reimbursement strategy there's been for mental health, and it's never quite been as on par as physical health issues, which unfortunately give our patients a very mixed message. I'll get into that a little more. The majority of older adults with mental health or substance abuse problems do not basically receive the treatment they need, and that only 1/3 of older adults who live in the community who need mental health services receive them. So there are 2/3 of folks who do not. And of course, when we're talking about mental health and treatment today, we have to be talking much more than pharmacology treatment. There are many more options. Research has shown, evidence has shown over and over that psychotherapy can be just as effective as a pill. And there's nothing wrong with medication as well, but sometimes we forget that psychotherapy is critical as well, and some of the other interventions we'll talk about today. So we're talking about a public health crisis in many ways, and our current prevention services are very limited. Older adults with mental health problems are more likely than younger adults to receive inappropriate or inadequate treatment. How many people have been told when they finally do say, I'm feeling a bit down, they may typically hear, well, what do you expect? You're older, you're dealing with losses, of course you feel down. Well, in my book, that's not a good enough reaction. There's an attempt to normalize that they're not alone in that, which is very positive, but it's not good enough in terms of overall potential intervention and engagement. So I think there's been a lot of research and growth in research on the causes and treatments of psychiatric problems in older adults. That always doesn't get implemented, though, in terms of prevention strategies and even treatment strategies. So some of the challenges we face are just the sheer numbers, the dramatic growth in older adults, the shortage of professionals in geriatric mental health care, and there was a recent IOM report in 2012 that really...
Maxine Green.
Sorry about that. Sometimes
Yeah, sometimes we have this. Maxine, if you can hear us, please go
Yes.
ahead and dial *6 to mute. Thank you very much.
Okay, so there's, as a result, a lack of access to care and underinvestment in knowledge dissemination, service development, and research to meet future needs. So these are some of the challenges. And as a result, there's an expertise gap going on due to the inadequate training in geriatric care. You know that better than I. You know, people aren't running to our fields of aging and geriatrics. And then combined, there are less people even running to mental health with geriatrics to work in this area. So, and the expertise gap, too, is sometimes there has been some evidence, but it isn't always translating into practice. So, very important. So the impact is the population will increase. We know the boomers, you know these demographics better than I. But what are we going to do? So the mental health part is that at least 1 in 5 people over the age of 65 has a significant mental health disorder, and the total number will double over the next 30 years. And that includes more than 16% with a primary psychiatric illness, 3% with dementia complicated by psychiatric symptoms. This is a huge area, the behavioral side effects of dementia. If we know what our numbers are going to be, and we're talking about half of the people over 85 may have some dementing illness, we're talking about a huge number that will have a co-occurring or psychotic presentation or at least depression. So we're really in a tough play in terms of gearing up for this. So we know that the numbers are there, but just like we know in all of aging, are we going to have the power and the infrastructure and the resources to address the needs? So, again, I think that the other piece that's a really important takeaway is that we forget the suicide population is higher among older adults than any other age group. It's been proven time and time again, yet very few resources going into suicide prevention with older adults. And the few programs that did exist years ago aren't necessarily as robust as they were at one time. And that has to do with the whole diminishment of mental health services. But now as things are devolving, more than ever, we have to keep older adults and their mental health needs on the forefront, else those programs are going to get lost totally. So there are great disparities, too. We're talking about the minority becoming the majority and not that many years off. And how do we think about our mental health services differently from people with different cultures and different backgrounds, and taking their values and preferences into fore? We have higher levels of depression among Hispanic elders, greater anxiety around non-Hispanic whites, particularly immigrants. We're seeing in one of our programs that I'll talk about a fair amount of post-traumatic stress disorder in so many different immigrant populations. The research for older African Americans is very mixed, but we know low socioeconomic status can be a real factor. So we have a lot of areas where our cultural competence is lacking on top of it, and this is like the triple whammy: aging, mental health, and then minority issues, and they're all coming together. There's even the potential for more people falling through the cracks. So there's this great disconnect, as I was just mentioning, between the aging and the mental health systems. They kind of grew up separately and in parallel ways, and often we don't talk the same language. We don't think about things in a similar way. And again, because of that lack of parity, there's limited access, and there's poorly integrated systems between the mental and the physical health care that we're talking about. Even if you look at a lot of our community-based aging programs out there, thinking about frailty and supplementing services so people can stay in their homes, there's rarely a mental health component in that. Maybe it touches on depression, at least in the screening, but there's not a lot very often in terms of the follow-through there. There were great attempts over the last 15 years to develop mental health and aging coalitions in different states, and some of you may still have those. We still have one in Illinois. And to bridge those two different divides, those silos, that overused term. but it's really critical because how do we bring it together? Because when we bring the service together, there's been evidence that clearly shows that when a mental health center has a specific older adult program, they have a greater tendency of people seeking services because the older adults, either there's an outreach component, a home visit component, or they, at least an older adult will have a sense that they will be known if they go to that program, or that someone will know about aging and treat them in a different way. So that's very important for us to think about. So some of the barriers are the system barriers, the fragmentation, a need for the integrated mental health services in primary care, long-term care, which I have just touched on the community-based side of long-term care, but if we talk about the inpatient, the residential side of both assisted living and nursing homes, there are so many unmet mental health needs. It's extraordinary, and this has been an ongoing issue for many, many years. Then there's the training barriers, the limits of traditional educational approaches and changing provider behavior and ageism. Even those mental health professionals are out there. They, whether they're psychologists, psychiatrists, social workers, you name it, there's sometimes still a bias. I mean, there are many, dinner parties I go to when people look at me and say, you do what and why do you do it? And do you really think it makes a difference? And how depressing to do what you do. There's just so much loss, and that hasn't been my experience, between the wisdom that an older adult presents and that wish to make changes, and maybe even a greater openness to make those changes because maybe they have more time in their life to think about those things because they might be in a more retirement state. It's been a privilege to work with them from a mental health perspective. So the financial barriers, too, are this mismatch between what's covered and what's not, our changing system of long-term care and community-based services. Every state is shaking in their boots about what is managed care going to bring. Is behavioral health, mental health actually going to be at the table as an equal player? Is it going to be integrated when we think about health outcomes? All the above. And then there's the consumer barriers, the stigma, the education. We'll get into that. So for the older person, that stigma they may feel is due to the age, their racial and ethnic background, being from rural communities, that they think, I'm not about to go to a mental health professional. So the importance of they see their physician or their primary care entity as somebody they might be able to talk to about these things. And how do we make it so the person they finally do talk to is open to hearing it and open to addressing it is the trick. So often, older adults focus on more somatic problems. I have a pain here, I have a pain there, but really sometimes this cohort, there's a hesitancy to discuss the psychological issues and symptoms that go with worry and stress and loneliness and social isolation. This may change in the future for those of us who have been more therapy privileged, psychotherapy privileged in our lives, and we've sought services ourselves. But time will tell. I'm not convinced. I think, who knows what will happen to us when we get old and we feel some of those losses and some of those fears. Are we going to be open to the pain we might be feeling? So for the provider, the barriers, again, have to do with that lack of knowledge of how someone might present with mental health problems and those treatment complexities that go along with older adults, those comorbid conditions that we talk about, that depression and diabetes, for example, that how often medical conditions mimic psychiatric ones or vice versa, that there can be a heightened sensitivity to medications and a reluctance to inform patients of a diagnosis. So even when someone does go on some medication for an antidepressant, for example, they may have been convinced to take that medication because it will help with their sleep. So what they'll do is they won't take the antidepressant as prescribed on a daily basis. They'll take it just when they're having trouble sleeping, which isn't going to work. So sometimes when we do finally engage the older person and find an acceptable way for them to accept some treatment, there can be a miss because they don't fully understand what's going on with it. Maybe because they don't want to, maybe because we haven't described it in a safe enough way. So And there's a scarcity of mental health professionals who know aging and vice versa. For the system, it's complicated because we can't depend on primary care alone. Most primary care physicians, I don't know if any are on the phone, they have about 12 minutes to meet with patients. So it's fully understandable that they're going to deal with some physical concerns first. Then there's all the financing silos. There isn't usually an extra payment. If you have a mental health person in your practice, it can be very convoluted and confusing in terms of how to get a service like this reimbursed. I think there's more attention to it now, but I think we have a ways to go. And, this is where we so don't have the intra and interagency collaborations to create this network of mental health and aging care that everywhere from the gatekeeper who may be out on the street noticing that someone's not doing well to someone who is very much a medical professional. We don't find the way to interconnect those things and create that safety net and that needed continuity of care that we're talking about. So there is a lot of evidence and models that are out there and showing that there's some success, and we're creeping along with that. But there's emerging evidence, but there still needs to be some research in this area because no matter how much is shown as best practices, it doesn't always get translated. We can talk about that too. Some of you researchers may have an idea why. So the evidence-based reviews show the greatest support for models that are effective in this area are community-based ones. Again, where we have the ability to go to someone's home, where we have the ability to do screenings, where we have the time to maybe engage someone that's reluctant to be engaged, to meet them on their own ground, to try to figure out what their goals are, to use motivational interviewing, whatever it may be, to try to get them comfortable to accept help. That we need teams, and it's not just these are people that sometimes take more of a village, and we haven't created that village very often. We got a lot of solo practitioners working out there, or we have people in senior centers who are staff who haven't been trained to identify people with mental health needs, who are running into them all the time and not knowing what to do with them. One of the best examples from my career was probably 20 years ago when I was working in a community-based agency that had a full spectrum of services, and we did such a nice job training the homemakers, training the bus drivers to really look for signs and symptoms of problems. And a woman was sitting on the bus and telling the bus driver how down she was feeling, how she was quite depressed, and she did even think about hurting herself at times. And the bus driver called us. We met the bus when she got off at her house. We intervened. We talked to her. We stabilized the situation. We got her the help she needed. But we wouldn't have been able to do that if the bus driver hadn't been the eyes and the ears, and then had a team to fall back on, to all be involved to try to help this woman. And, that's just a basic, perfect example that doesn't happen enough because of the systems we've created for care. But we know that people are more willing to accept services where there's a team and different people trying to be involved with them. They sense the hope that we as a team feel for their future, which is really important. So that whole notion of collaborative, integrated services, I think, is the direction we're going. So there's no easy way I can tell you this, so I'm sending you to someone who can. That's kind of what I'm trying to say there, that it does take all of us. It can't just be one of us. But it's got to be someone that kicks it off somehow, whether it be that physician sitting behind that desk or that bus driver that I just described. So we're talking about a bunch of interdisciplinary geriatric mental health programs, and there have been some great outreach services designed to detect and treat mental health problems in settings where older adults live, spend time, and seek services. Very important. Anything in the way of outreach, prevention. Then there's the whole, I have a group full across the way because today is National Memory Screening Day. We must have 60 people lined up to have their memory screened. It's become is as hard as it is for people to think about memory impairment. It is remarkable how much people sign up for a memory screening like that, and we probably have the same 50. It's taken us a while for a depression screening day, 50 to 100. That's a little harder sell. It's interesting that memory becomes more acceptable in some ways, but these kinds of things to raise the gauntlet on these issues is critical to normalize it so people will come in for those sorts of things. But again, not everyone can come in. We have to go out. There's been an interesting program called Patch out of Hopkins, and some of you may know about it. It attempts to improve and coordinate community services to older adults and to educate caregivers about their special needs. Again, caregivers are a critical component. Family caregivers can sometimes make or break a potential for intervention. Too often, the family who doesn't really want to hear that their father or mother are in pain, that it's too easy to kind of slide across what they might be hearing and just ignore, not purposefully, of course, but it might just be too hard for them. So it's really important to, when you think about all of this, how important it is. And I know GECs have been doing a lot with family caregivers over the years, and it's so important for them to realize and look for signs and symptoms of mental health issues as well. There's been the PEARLS program, and it stands for the Program to Encourage Active, Rewarding Lives for Seniors. It's a short-term, in-home treatment program designed to reduce depression in physically impaired and socially isolated seniors. And it really uses a problem-solving social and physical activation approach and has increased pleasant events for many people to reduce depression, because so much of it is just not feeling like there's enough meaning in their lives, and that's really made a difference. So that's an important program to look at, PEARLS. Then there's Healthy Ideas, and it's very much an evidence-based disease management for depression, and comes out of the Huffington Center on Aging. The goal of Healthy Ideas is to detect and address depression through effective evidence-based screening and health promotion education. If you're familiar with some of the evidence-based programs out of Stanford, it's somewhat modeled after that as well and has showed great effectiveness. And then there's the HOPE study, which has shown some effectiveness as well to improve psychosocial functioning and reduce long-term medical burden in older people with severe mental illness. Not enough focus on severe mental illness. So much of when there has been attention to mental health around for older adults, it's been more about depression, anxiety, dementia, a little about substance abuse, but we really have missed the more severe mentally ill population. So it's good to know there's a program there. Some of the more evidence-based programs that are specifically for older adults with an integrated collaborative component are the PRISM-E that comes from SAMHSA and Veterans Affairs and HRSA. Been a very successful program. Prospect that Marty Bruce has developed and has taken that to home environments as well, looking at suicide prevention in primary care older adults. And then the impact work that Jürgen Unitzer has done, which stands for Improving Mood and Promoting Access to Collaborative Treatment. So those are kind of the gold standard programs that people have talked about, very important. Then there's the gatekeeper model, which I can't say enough about, that really came out of Spokane, Washington, where it really recruited community service professionals, personnel from meter readers to utility workers to landlords to hairdressers to grocery store owners to identify and refer at-risk older adults. They went out and trained and made them, part of the village, part of the ambassadors for mental health, to begin to detect and see and have a number to call if they saw somebody who they were concerned about. So it's been a perfect model, replicated in some other places in the country, and so effective. Then there's cognitive behavioral treatment. Can't say enough about cognitive behavioral in terms of its evidence. Very effective, particularly with older adults, because of the cognitive distortions that do indeed go on. Then problem-solving therapy has become more and more important, particularly in home-based settings. That's been very exciting to see some work, home-based settings with PST. And then, of course, it may not have the evidence, but I think a lot of us know from practice who come from a more psychodynamic perspective that therapy with older adults to help them cope and understand with their unresolved issues and conflicts is still very legitimate, whether they're 60 or 90 or even 100. So that's very important. I think the overall message, though, is one that I took from Thoreau, which is if you build castles in the air, your work need not be lost. That is where they should be, but we need to put foundations under them, and that's so often what's missing in this arena. So let's talk about some of the barriers to implementation. Implementation of these interventions are limited, and it often comes to money. It often comes to drive and just people not believing there's effective treatment. And even though there are the resources there, then there's a whole ethnic minorities on top of being older and less educated patients are more likely to be subject to treatment disparities and receive lower quality of care than our other depressed patients. It's been proven, it's been shown, and it's quite unfortunate, but it's true. So that lack of collaboration and coordination between providers is very heightened. So often, the primary care doc never hears that, of course, a homemaker dealing with a very depressed person in the home because we haven't set up that kind of care coordination, that teamwork where the physician will see that the home care aide is just as important as part of the picture in telling how their patient's doing as it is for the home care aide to hear the physician's thinking. But that kind of work, that kind of crossing through our systems does not work and does not happen as much as it should. There are a few examples where it does, PACE programs, et cetera, but of course we need more of that. So there's different levels of expertise between primary care, long-term care, and especially mental health providers, and how do we either level the playing field somewhat in terms of at least recognizing problems, but more important, knowing and helping people refer to each other when that's needed. So when we're talking about the fragmentation, just get a sense of all of what we're dealing with out there, and I'm sure I'm missing many people. But there are many people who are part of the so-called team but not formalized as a team, and as a result, the fragmentation creates incredible barriers for good care. The aspect of the shortage of professionals is extreme. We're talking about the demographics being what they are and needing more medical and social service professionals in this area, but we have such a shortfall. And you can just get a sense of how small the numbers are and how do we gear up in terms of what we need. This has been an ongoing discussion by many people in geriatrics. You, more than anybody else, knows this. And the recent IOM report, of course, reinforced that too. So there's this shortfall in terms of mental health interventions, and we have nearly half of older adults with a recognized mental health disorder have unmet needs. So it's a perfect storm. Primary care is something that, again, I think is the sweet spot of potential intervention if we can figure out how best to do it. We so often at Rush have approached our various primary care clinics and wanted to either co-locate or be a virtual wraparound. And it's amazing how sometimes rather than being embraced with open arms, and I know this happens in other places too, there's more of a suspect of, well, why do you want to get involved with our patients and that sort of thing. So how do we get over that, come to a common mission and vision, and see the value in bridging those gaps? Because, the care delivery models we have are not necessarily working, and we need to bridge those gaps and to improve outcomes and overall health, which is critical. So Steve Bartels, who's a guru in this area, talked about older persons with psychiatric illnesses, of course, are more likely to receive inappropriate pharmacological treatment and less likely to be treated with psychotherapeutic interventions than younger primary care patients. And that, of course, is critical, and that's some of the ageism I was talking about. So physician education is a priority, but all of education for us is a priority. I've heard social workers that are just as age biased as other professionals and thinking, oh, why bother with an older adult? So we have to get over that. We have to find ways to get these messages out there that talk about even this whole area of 30-day readmissions, which is the hottest, hot area for healthcare reform. It's showing that some of the highest people who readmit to hospitals within 30 days, older adults, also have a co-occurring mental health issue, often depression. So how do we raise the flag on this, saying we can help if we address this mental health issue? Please, know that we're going to have an overall meeting that triple aim that everybody's concerned about: better health, better care at a lower cost. So that whole care management, that whole collaboration between mental health care and co-locating within primary care or wrapping around it is a critical one. As a result, we started the Brighton program a couple years ago at Rush, and we really brought together a virtual team because we had done some work about virtual teams of the patient, hopefully, psychologists, psychiatrists. We included social workers, and then we included some people who aren't typically on the list for mental health providers, but really we found can have an unbelievable influence. Physical therapists, occupational therapists, nutritionists, the number of people who were willing to talk about nutrition and that their nutrition was affecting their anxiety and depression was unbelievable. Chaplain, pharmacists, that really became our team. And basically, we sent this questionnaire and had this questionnaire in every primary care practice we were working with, and on every front of a medical chart. So either this could be filled out when somebody was, the PHQ-4 could be filled out when somebody was sitting in a waiting room and they'd put it in a yellow box because that was our theme, or it would be on the top of their chart, and hopefully the medical assistant, when they were taking their blood pressure, when they were putting them in a room, would also do this little short questionnaire with them, and it would trigger a referral to us. And it worked very well, and it's still working very well. We went from a small grant with Retirement Research Foundation to a SAMHSA-funded grant to now we're part of an NIH study looking at how to reduce anxiety and depression, particularly older adults with metabolic syndrome, diabetes, heart failure, those sorts of things. So you have a sense that we wrapped around virtually the practices, and it's worked quite well. For the most part, sometimes it's harder to get the primary care folks involved, but we're not sure if it would be any different if we were sitting there co-located. But some of our results have been quite tremendous in terms of reducing depression, the number of people, and we really have had a very multicultural group of people, and the people who have been who have agreed to engage in psychotherapy has been quite dramatic. So you can see over time we've reduced depression, we've reduced anxiety, and it's been an exciting project, and particularly around the notion of how to integrate with primary care. But the other part of this, which is a very important component, which I didn't create a slide for, is we felt that there was a lack of geriatric mental health trained professionals, and we developed a fellowship for both psychologists post-PhD and social workers post-MSW. So we've graduated 5 or 6 years of fellows who have gone through the program, who we've really it's been an evidence-based a deluge of learning and clinical work for a year-long fellowship that has been extraordinary in terms of what we've been able to produce in terms of a future cohort of practitioners. We wish we could keep it going. We're trying to figure out ways to do that. So, as we try to keep and think about ways to do that, we have to think about policy. And the policy area has been building. I mean, there's the Surgeon General's report in '99, the President's New Freedom Commission on Mental Health in 2002, a White House Conference on Aging in 2005, that all said the same kinds of things. This has to be recognized. It is critical. et cetera, et cetera, et cetera. How do we build this into our work with older adults? And the Older Americans Act even added a mental health services screening component. They wanted to focus more on mental health issues, and even that hasn't really been fully funded, the Older Americans Act, but particularly the mental health piece. There's the Positive Aging Act that really, really tried to address some of this in terms of, which has still not been passed. It's going to go up again. But the notion behind it was to bridge the mental health and aging divide, to try to put somebody in SAMHSA, the mental health agency of the federal government, who had aging expertise. And then it tried to then put somebody with mental health expertise in the Administration on Aging, now called the Administration for Community Living. And it was endorsed by a broad range of mental health and older adult organizations. But it never made it through, unfortunately. And the emphasis here, too, was to really make sure primary care was a setting that this could be played out in, a venue that it could be played out in, bridging the mental health and aging. The IOM report that I mentioned it provided a systematic and trend analysis, a very good one. It considered ethnic needs. It weighed in on the impact of improved diagnostic techniques, how important it is. The findings were very clear. How do we shift from a medical model to more of a public health model? How do we implement a systematic recruitment and retention strategies to improve and build the workforce? How do we improve training effectiveness? And then how do we look at developing reimbursement options and to keep some of these models of care going in ways that we haven't been able to? So often, as you know, there's a good program out there. It gets some funding. The funding goes away. The program goes away. How do we change that? The National Coalition on Mental Health and Aging is one that's out there. It's been in existence for many years. It has 80 members and organizations. It's working on this issue all the time from a policy perspective. Feel free to look at their website. I, who was very involved in starting the ASA, American Society on Aging, and the Mental Health and Aging Network, too, it's a great place for people to coalesce around both learning more about these issues, learning best practices, and influencing policy and research. So, just to conclude, and hopefully we have plenty of time for questions, and I hope we'll be able to do that, Dean, is that the goals of mental health intervention are really, as I see it, to bridge the mental health and aging services with primary care, I would say, to focus on decreasing the stigma of mental health problems, to increase the understanding of depression and anxiety in older adults. Very much this has been tried, but I think it's always worth trying again, more of a social marketing campaign about the importance of addressing depression and anxiety if you are an older adult or if you're a family member, and then all the policy changes that need to be addressed that I just mentioned. So I hope, and my vision and values for this is that we can try to develop more systematic screening to identify mental health problems, that it become a part of every healthcare visit, because things can change so much for older adults, that we try to replicate what's working and eliminate what's not, that we try very much to look at cultural sensitivity within the context of services in order to reduce disparity, and we try to integrate those silos, whether they need medical, mental health, social service, long-term care, and then, of course, more investment in training in this area. And just to end with one of my favorites, one thing is sure, we have to do something. We have to do the best we know how at the moment. If it doesn't turn out right, we can modify it as we go along. And I think it speaks well to what we've been doing in this area and how much more there is to do. So, no older adult should have to live with the symptoms of depression and anxiety and all the other things that they face. And I think that's what we all have to embrace when we're thinking about this work. So with that, I'll turn it back to Sue or Dean, and are we able to have some questions?
We sure can. For those of you who have muted, go ahead and hit *6 again to unmute. And you're also welcome to type into the chat as well.
Have someone typing.
As we wait, this is Sue. I just want to thank you so much, Robin. Such great EBP, evidence-based practice programs to refer us to. Those were great. And
it's critical, Sue. Thanks.
Right. I think a number of us will probably be going back to those slides. I know I will.
Great. And definitely look at the most recent IOM report. I can't say enough about it. It was a stellar piece of work.
Okay.
Sometimes Institute of Medicine reports sit on a shelf and get dusty, so.
Okay, we'll do that. And one of my sayings I'm a saying collector for those that don't know me, and one of them was, there's no health without mental health.
Absolutely. Perfect. Okay, so Teresa Gordon asks, what do you think the impact of mental health parity in the ACA will have on aging services? Teresa, I hope it'll have a positive impact. I strongly feel that the message for older adults over time, when they use their Medicare, for example, and they got a bill for mental health services that they might have been seeing a therapist, and they got a Medicare bill that only paid 50% of that bill and were expected to pay 50% of the copay, as opposed to when they went to their podiatrist and it was 80 to 100% covered, gave a very subtle, unfortunate message to them that reinforced that, well, what's this mental health stuff about? If it really is effective, why did they reimburse at a lower rate? So I thought that was, I thank goodness for parity, and let's hope it all gets rolled out. But I do feel that I think people accepting the services will be greater as a result, because they won't see that lack of parity, and the less stigma associated with it. But I think providers, too, may finally embrace the importance, so I can get paid for this. So maybe it will be more infused into primary care clinics, et cetera, et cetera. So I'm hoping for the positive. So much of it is, how do you get the mental health community at the tables where a lot of this is rolling out? The medical home discussions, the Medicaid discussions that are going on statewide, the integration projects, the accountable care organizations. How do you get mental health at the table? It needs to be. So that's a big trick. So Denise asked, very interesting lecture. I have had many patients with dementia as well as schizophrenia and bipolar disorder with behavioral issues. And family is asking for placement, something to inability to care for them, of course, caregiver burden. But finding long-term care places able to care for patients with mental health is extremely difficult here in Washington, D.C. Well, Denise, don't think it's any different anywhere else. And this is a huge area. And that's why so many, why there isn't more supportive living environments as opposed to just skilled care nursing homes that are focused on people with mental health conditions is beyond me. But it has to do with reimbursement and scalability. So they're throwing people with mental health and acting out kind of conditions into, nursing facilities that don't necessarily know how to best treat them from a cultural perspective. So it's an incredible missing piece, the housing, safe housing, sensitive housing aspect of this that I'm not sure who's doing well. I mean, remember, there are very few even geropsychiatry units left in this country because the reimbursement was so poor that a lot of them closed up. Yeah, so just persuaded many subacute. Oh, absolutely, the subacutes won't touch someone even if they have diagnosis that's kind of lower on the list. It's horrible, and this is where the whole notion of rebalancing and money follows the person. All of those efforts, I think that's the piece where so many people aren't able to leave more restricted settings because the mental health services are not out there for them because of this. So I only wish I could have a better answer for this one. So
Hi Robin, this is Linda Redford. How are you?
Hi Linda, how are you?
I'm fine. Sorry, my name isn't on the thing. I'm in somebody else's office. But I wanted to thank you for your comments and reiterate the whole issue of the mental health, the kind of mixture, particularly of mental health and cognitive issues. And mental disease. We've been having a very difficult time finding experts who can talk on that to other health professionals. They want to talk on cognitive problems, or they want to talk on mental health problems, but those mixtures.
Yeah, absolutely. It's a very small crowd. And unfortunately, Linda, I mean, the numbers are going to be huge.
I know, exactly. But I do also want to emphasize that IOM report. It's excellent.
Now, I do think the American Association of Geriatric Psychiatry has embraced the more behavioral side of dementia, too, so they may have some expertise there as well, so they would be good partners to have. But thanks. It's so important. I also want to... Go ahead.
We just need a lot more geropsych people.
Well,
even in our urban area, they're hard to find.
Oh, my gosh, absolutely. My rural friends think, it's so much easier in the urban areas. Not true. We have so many psychiatrists who have gotten out of geriatrics because of the reimbursement issues. It's just very sad, very sad.
Yeah.
And it takes forever to find one to see a patient.
Yep.
That's why I think we have to look at nurse practitioners as well as a strength in this area, particularly who specialize. And I hope I didn't leave them out, but I think they're critical in this discussion. Also, Green mentioned in the Washington area, it's compounded when people have a dual diagnosis with substance abuse, and I can't reinforce that enough. If we think there's not enough mental health services, there's even less in the way of substance abuse. There are really rare places that an older person, or anybody can even detox. Point. So it's a horrendous time, unfortunately, for that. And again, this is where we always have to have our policy hats going.
Exactly. Thanks so much for bringing that up, too.
Thanks. Other questions?
Hi, Robin. This is Marla Bergwager.
Hi, Marla.
How are you? So great talk. Thank you so much. So here's my question. In a couple of weeks, I'm speaking in a colleague's MSW clinical diagnosis course. What is if you had to say what message, what pearl of wisdom you want me to leave with them about this issue, what would you say?
That they should be aware of their countertransference.
Ah, okay.
Yeah, that their own biases, their own ageism, their own feelings about it. I mean, this is an area where all of us who work in this area usually are confronting it a bit in our personal lives, too. Mm-hmm. So it's really important you separate out what you would be doing versus what with your parents versus what you think the daughter should be doing versus what you think the older adult should be doing based on what you know. It's very much, you got an assessment, really understand where the person is coming from, empathy, all the basics, yet really be aware of your own countertransference, because I think that's the piece that doesn't get addressed by so many other professions, that the biases we have can get in the way of whether or not we create hope for someone. And whether or not we create hope is whether or not they'll be engaged in treatment.
Right, because based on past experience with pretty much any class except Sue Tebb's geriatric class, if I have one or two people in that whole room who are interested in working with older adults, I'll be excited. I think this is a great message to leave them with. So thank you.
Well, and there's so much possibility, as you know, Marla, for change and growth. That's what you talk about too. Try to seduce them into the field.
Right. Oh, absolutely.
You know that better than I.
Thank you.
Any other thoughts or questions or disagreements or whatever?
This is Janet Head in Missouri, and you mentioned just briefly now the rural versus urban. I'm curious if any of the programs that you mentioned as best practices were implemented in rural areas, if they had.
I know Healthy Ideas and Pearls have been. So, you should check that out on their respective websites, but absolutely, I know of some. So, it can be done. You know, it's like the struggle with everything else in rural areas. The distance. But, you know, I think this is also an area where telehealth may really come into play down the road. And hopefully there are some, you know, still ongoing reimbursement issues for telehealth and mental health, telehealth, and hopefully that can be sorted out at some point, because I think it could be very effective.
Well, there clearly are different people involved and a variety of different issues that you face, but just curious about if there had been any looking at this works best world, that works best.
Not that I'm aware of, but I just might not have delved deep enough.
Yeah, it was nice to be reminded that urban areas have their issues as well.
Oh, my God. Trust me. Let me know what you find.
Okay, thanks.
Thank you.